Welcome to today's lecture on endocrine and hematologic emergencies. In this session, we'll explore the critical functions of the endocrine system, glucose metabolism, diabetes, and various hematologic disorders. Understanding these conditions is essential for EMTs, as they can present life-threatening complications requiring immediate intervention. The endocrine system is the body's communication network, using hormones to regulate essential functions. Glands throughout the body secrete these chemical messengers, which influence organs, tissues, and cells. When communication breaks down, endocrine disorders develop, leading to serious health complications. One of the most important roles of the endocrine system is glucose metabolism. The brain requires glucose and oxygen to function properly. Insulin, a hormone produced by the pancreas, is essential for glucose to enter cells and provide energy. Without enough insulin, cells cannot absorb glucose, leading to serious metabolic disturbances. The pancreas plays a central role in glucose metabolism. It produces two key hormones, glucagon from alpha cells and insulin from beta cells. Glucagon helps raise blood sugar levels by signaling the liver to release stored glucose, while insulin lowers blood sugar by allowing glucose to enter cells. Diabetes mellitus is a chronic condition that disrupts the body's ability to use glucose for energy. If left untreated, high blood glucose levels can lead to severe complications such as blindness, cardiovascular disease, and kidney failure. It is crucial to recognize the symptoms of hyperglycemia, high blood sugar, and hypoglycemia, low blood sugar. Both conditions can occur in patients with type 1 and type 2 diabetes. Hypoglycemia requires immediate treatment, as it can lead to seizures, unconsciousness, and brain damage if left untreated. Type 1 diabetes is an autoimmune disorder in which the body attacks pancreatic beta cells, preventing insulin production. Without insulin, glucose cannot enter cells, and the body cannot generate energy. These patients rely on external insulin sources to survive. Type 1 diabetes typically develops in childhood or early adulthood. Because their pancreas cannot produce insulin, these patients must use insulin injections or an insulin pump to manage their blood sugar levels. Many type 1 diabetics use insulin pumps, which continuously monitor glucose levels and administer insulin as needed. However, these devices can malfunction, leading to dangerous swings in blood sugar levels. Always ask a diabetic patient whether they use an insulin pump and check for signs of malfunction. Newly diagnosed type 1 diabetics often experience symptoms such as polyuria, frequent urination, polydipsia, excessive thirst, polyphagia, excessive hunger, unexplained weight loss, fatigue. Recognizing these symptoms early can help prevent severe complications. A normal blood glucose level is between 80 to 120 mg/dl. When blood glucose levels rise too high, the kidneys become overwhelmed and glucose spills into the urine, which can lead to dehydration and further complications. When glucose is unavailable, the body starts breaking down fat for energy, producing acid waste known as ketones. As ketone levels rise, they spill into the urine. This leads to an acid-base imbalance, and the body compensates by increasing respiratory rate, known as Kussmaul respirations. Uncontrolled fat metabolism can lead to diabetic ketoacidosis, DKA, a life-threatening condition. Symptoms include abdominal pain, nausea and vomiting, body aches, altered mental status, rapid, deep breathing, Kussmaul respirations. If DKA is not treated promptly, it can result in coma or death. A glucose reading higher than 400 milligrams per deciliter often indicates DKA. This is a medical emergency requiring immediate transport to the hospital. Type 2 diabetes occurs when cells resist the effects of insulin. The pancreas compensates by producing more insulin, but over time, insulin resistance worsens. Obesity is a major risk factor for type 2 diabetes. Treatment for type 2 diabetes includes oral medications, injectable insulin, lifestyle changes, and dietary modifications. Exercise and weight loss can improve insulin sensitivity and reduce the severity of the disease. Many patients are diagnosed with type 2 diabetes during routine medical checkups. Symptoms such as frequent infections, vision changes, and numbness in the feet often signal underlying high blood glucose levels. Early diagnosis and management can help prevent serious complications such as neuropathy, kidney disease, and cardiovascular issues. Hyperglycemia occurs when blood glucose levels remain elevated for extended periods, leading to significant complications. In type 1 diabetes, hyperglycemia can result in diabetic ketoacidosis, which is caused by the breakdown of fat for energy in the absence of insulin. In type 2 diabetes, prolonged hyperglycemia can cause hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS, a severe state of dehydration that requires emergency medical treatment. When hyperglycemia persists for long periods, patients may experience serious complications, including wounds that do not heal, numbness or tingling in the hands and feet, vision loss, kidney failure, and digestive issues. As an EMT, recognizing these long-term effects is important, but immediate interventions focus on stabilizing the patient's condition and preventing further deterioration. When blood glucose levels are poorly controlled in type 2 diabetes, hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS, can develop. This condition presents with severe dehydration, confusion, drowsiness, lethargy, excessive thirst, dark urine, and potentially seizures or paralysis. Patients in HHNS require immediate fluid resuscitation and transport to a hospital. As glucose levels continue to rise, excess sugar is excreted through urine, which leads to significant fluid loss and dark, concentrated urine. The patient may become unconscious or experience seizures due to the severe dehydration associated with HHNS. As an EMT, your role is to monitor vital signs, assess for signs of dehydration, and ensure rapid transport for definitive care. Hypoglycemia occurs when blood glucose levels drop too low and must be corrected immediately. This condition is most common in patients who take insulin or oral medications that stimulate the pancreas to produce insulin. When insulin levels are too high, glucose is rapidly removed from the blood, depriving the brain of its primary energy source. If not corrected, hypoglycemia can quickly lead to seizures, coma, and death. As blood glucose levels drop, the brain is one of the first organs affected, leading to altered mental status. The patient may appear confused, combative, or display unusual behavior. If hypoglycemia is not treated promptly, the patient may lose consciousness and suffer permanent brain damage. Immediate intervention with glucose administration is critical. There are several common reasons why a patient may develop hypoglycemia. A patient may have taken the correct dose of insulin but then changed their eating routine, skipped a meal, or engaged in physical activity without adjusting their insulin intake. Other causes include taking too much insulin or developing an acute illness that affects blood sugar levels. Signs and symptoms of hypoglycemia include shallow or rapid breathing, pale and clammy skin, excessive sweating, dizziness, headache, and a rapid pulse. Unlike hyperglycemia, which develops gradually, hypoglycemia can progress rapidly, leading to an emergency within minutes. Immediate glucose administration is necessary to reverse the effects. In addition to physical symptoms, patients experiencing hypoglycemia often exhibit signs of altered mental status, including anxiety, aggressive behavior, weakness on one side of the body, fainting, or seizures. Because symptoms develop quickly, EMTs must act fast to assess glucose levels and administer appropriate treatment. Hypoglycemia is one of the few medical emergencies that can be rapidly reversed with proper treatment. If the patient is conscious and able to swallow, oral glucose or a sugary drink can be given. If the patient is unconscious or unable to swallow, EMTs should provide high-flow oxygen and transport the patient immediately for glucose administration at the hospital. When responding to a diabetic emergency, scene safety is the first priority. Patients with diabetes may have syringes or medications at the scene, which can provide clues to their condition. Always use standard precautions and gather information from bystanders about what led up to the emergency. Keep an open mind and assess for other potential causes of altered mental status, including trauma or intoxication. The primary assessment begins with forming a general impression of the patient. Assess the airway and breathing, especially in patients with altered mental status or inadequate breathing. If oxygen saturation is below 94% or the patient shows signs of respiratory distress, administer high-flow oxygen at 12 to 15 liters per minute using a non-rebreather mask. Patients with hyperglycemia may exhibit rapid, deep Kussmaul respirations and have a fruity odor on their breath, which indicates the presence of ketones. In contrast, patients with hypoglycemia may present with normal or shallow, rapid respirations. Carefully observe the patient's breathing pattern to help determine whether their blood sugar is too high or too low. Circulation assessment is another key step. Patients with hyperglycemia typically have warm, dry skin, while hypoglycemic patients often appear pale and clammy. A rapid, weak pulse is a sign of symptomatic hypoglycemia, while hyperglycemia can cause a weak, thready pulse. Assessing skin condition and pulse quality can provide valuable clues about the patient's condition. Once the primary assessment is complete, determine the need for transport. Any patient with altered mental status or an inability to swallow should be transported immediately. Patients who are conscious, alert, and able to swallow should be further evaluated and may be treated on scene, depending on protocol. Rapid decision-making is crucial in diabetic emergencies. Gathering a thorough history is essential in diabetic emergencies. Ask questions such as, do you take insulin or medication for diabetes? Have you eaten today? Have you been feeling sick or stressed? Understanding whether the patient has missed a meal, taken too much medication, or experienced unusual activity can help determine whether hyperglycemia or hypoglycemia is the cause of their symptoms. A sample history should be obtained whenever possible. Ask the patient or bystanders about recent illnesses, insulin pump use, medication compliance, and any unusual activity. This information helps EMTs decide on the most appropriate treatment and whether the patient needs immediate transport. During the secondary assessment, conduct a head-to-toe evaluation with a focus on mental status, airway protection, and circulation. Check blood glucose levels using a glucometer if available and follow local protocols. Vital signs, including pulse, respiratory rate, and skin condition, should be reassessed frequently. Continue to monitor the patient's condition throughout transport. If the patient is hypoglycemic and conscious, encourage them to take glucose tablets or juice. If they are unconscious, ensure airway protection and prepare for rapid transport. Always document your interventions and communicate findings with hospital staff upon arrival. Using a portable glucometer is an essential part of assessing diabetic patients in the field. If available and permitted by your protocols, you should always check the patient's blood glucose level to determine whether hyperglycemia or hypoglycemia is present. Be familiar with the operating procedures of your glucometer, including its upper and lower limits. In a normal, non-fasting adult, Blood glucose levels typically range between 80 to 120 milligrams per deciliter, while neonates should have levels above 70 milligrams per deciliter. Frequent reassessment is crucial for diabetic patients, as their condition can change rapidly. Continue monitoring the patient's vital signs, mental status, and airway. If the patient is hypoglycemic, conscious, and able to swallow, encourage them to take glucose tablets or drink juice containing sugar. For unconscious hypoglycemic patients, prepare for rapid transport and anticipate the need for 4-glucose or glucagon administration at the hospital. If the patient remains symptomatic or their condition worsens, additional interventions may be required. In cases of severe hypoglycemia where the patient cannot swallow, you may need to administer glucagon intramuscularly, per local protocols. If hyperglycemia is suspected, focus on managing hydration and monitoring for signs of worsening metabolic acidosis. If a glucometer is unavailable, perform a thorough assessment, paying close attention to respiratory patterns, skin condition, and mental status. Contacting the receiving hospital for guidance may be necessary in some cases, especially if the patient's symptoms are unclear or if their condition is deteriorating. When in doubt, transport the patient and allow hospital staff to perform further testing and treatment. Communication and documentation are critical, especially if a patient refuses transport after symptoms improve. Clearly document all assessments, interventions, and changes in condition. Explain to the patient the risks associated with refusing care, particularly if they have experienced a hypoglycemic episode that could recur. Always follow your agency's protocols regarding patient refusals and documentation. The primary treatment for hypoglycemia is administering glucose. There are 3 types of oral glucose: rapidly dissolving gel, large chewable tablets, and liquid formulations. If the patient is alert and able to swallow, administer one of these options per your protocols. Remember to wear gloves before handling oral glucose and monitor the patient for any changes in condition. Oral glucose should never be given to an unconscious patient or someone who cannot swallow, as this can lead to airway obstruction. If the patient is unconscious, they will require 4-dextrose or IM glucagon, which will need to be administered by ALS providers or hospital staff. Always reassess the patient's condition frequently and prepare for rapid transport if needed. Seizures can be a result of severe hypoglycemia, making airway management a top priority. If a hypoglycemic patient experiences a seizure, ensure their airway is clear, roll them onto their side to prevent aspiration, and avoid putting anything in their mouth. Suction should be available if needed. If the patient shows signs of cyanosis or inadequate breathing, provide oxygen or artificial ventilations as necessary and transport immediately. Altered mental status is a common symptom of diabetic emergencies. When evaluating an unconscious or confused patient, use the mnemonic AEIOU tips to consider all possible causes, including alcohol intoxication, epilepsy, infection, overdose, uremia, trauma, insulin-related conditions, poisoning, and stroke. Always check blood glucose levels in any patient with an altered mental status, as hypoglycemia is a common and easily treatable cause. Ensuring a patient's airway remains clear is crucial when dealing with altered mental status. Be prepared to provide artificial ventilations if the patient is not breathing adequately. If the patient vomits, suction should be readily available to clear the airway. Rapid transport is necessary for any patient with persistent altered mental status. A common misdiagnosis for hypoglycemia is alcohol intoxication. Diabetic patients who appear confused, unsteady, or unconscious may be mistaken for intoxicated individuals. If a suspected intoxicated patient does not have a strong odor of alcohol, consider checking their blood glucose level. Many diabetics wear medical alert bracelets or carry identification cards, which can help in identifying their condition. Altered mental status due to hypoglycemia can lead to a loss of protective airway reflexes. If the patient becomes unresponsive, place them in the lateral recumbent position to prevent aspiration. Monitor for vomiting and ensure suctioning equipment is available. Oxygen should be administered as needed, and immediate transport is required for patients who remain unconscious or show signs of significant distress. Hematology is the study of blood-related disorders, which can lead to emergencies requiring pre-hospital intervention. For major hematologic conditions, EMTs may include sickle cell disease, hemophilia A, thrombophilia, and anemia. Each of these conditions can present unique challenges in the pre-hospital setting, requiring a solid understanding of their pathophysiology and appropriate management strategies. Blood is composed of four main components: red blood cells, white blood cells, platelets, and plasma. Red blood cells contain hemoglobin, which transports oxygen to tissues. White blood cells fight infection, platelets help with clotting, and plasma serves as the medium that carries all these components throughout the body. Any disruption in these functions can result in a medical emergency. Sickle cell disease is an inherited disorder that primarily affects people of African, Caribbean, and South American descent. In this condition, red blood cells take on an abnormal sickle shape, which leads to dysfunction in oxygen transport and an increased risk of clot formation. These sickled cells can obstruct blood vessels, causing pain crises and organ damage. Sickle cell complications include anemia, gallstones, jaundice, and dysfunction of the spleen. Because the spleen is responsible for filtering abnormal blood cells and fighting infections, patients with sickle cell disease are at higher risk of severe infections. Prompt identification and management of sickle cell crises are essential in pre-hospital care. Vascular occlusion occurs when sickled cells block blood vessels, leading to conditions such as acute chest syndrome, stroke, joint necrosis, and severe pain crises. These blockages can cause tissue damage and significant pain, requiring oxygen administration and rapid transport to a hospital. Many complications of sickle cell disease can be both painful and life-threatening. Patients may experience widespread vascular occlusion, leading to decreased oxygen supply to tissues and potential organ failure. These episodes, known as sickle cell crises, can cause extreme pain and require rapid pain management and hydration therapy. Hemophilia is a rare disorder that primarily affects males, with only about 20,000 cases in the United States. Patients with hemophilia have a decreased ability to form clots, making even minor injuries potentially life-threatening. Patients with hemophilia often take medications to replace or stimulate clotting factors. As an EMT, you should be aware that these patients are at high risk for internal bleeding, particularly in the brain, joints, and other critical areas. Some common complications of hemophilia include long-term joint damage requiring surgical intervention, spontaneous bleeding episodes, and increased risk of thrombosis due to overuse of clotting medications. Thrombophilia is a condition in which the blood clots too easily, leading to an increased risk of stroke, heart attack, and deep vein thrombosis. Patients may develop spontaneous clots without any apparent cause. Thrombophilia can be caused by genetic factors or lifestyle choices. Patients with this condition require ongoing medical management and may be prescribed blood thinners to reduce the risk of clot formation. Deep vein thrombosis is a common complication in sedentary individuals and post-surgical patients. To reduce the risk of DVT, patients may be prescribed blood-thinning medications, compression stockings, or mechanical devices that promote circulation. Risk factors for developing DVT include prolonged immobility, joint replacement surgery, and certain genetic conditions. Without proper treatment, a clot from a DVT can travel to the lungs, causing a pulmonary embolism. Patients diagnosed with DVT typically require at least 3 months of anticoagulation therapy to prevent complications. If a clot travels to the lungs, it can cause a life-threatening blockage known as a pulmonary embolism. Anemia is a condition in which there is an abnormally low number of red blood cells. This reduces the blood's ability to carry oxygen, leading to symptoms such as fatigue, weakness, and shortness of breath. When responding to a patient with a suspected hematologic emergency, always ensure scene safety first. Many patients with sickle cell disease will have experienced crises before and may be familiar with their condition. Always wear gloves and eye protection as a minimum standard precaution, and consider requesting ALS support for pain management or advanced interventions. During the primary assessment, determine if spinal immobilization is necessary. Begin by forming a general impression of the patient's condition. If you note signs of inadequate breathing, an altered mental status, or signs of respiratory distress, administer high-flow oxygen at 12 to 15 liters per minute using a non-rebreather mask. For patients in a sickle cell crisis, respiratory distress is a common presentation. They may have an increased respiratory rate or signs of pneumonia. If you notice any difficulty breathing, intervene quickly with oxygen therapy and prepare for immediate transport to the hospital. Circulation assessment is critical. Patients experiencing a sickle cell crisis often have an increased heart rate. If you suspect hemophilia, be on high alert for signs of acute blood loss. Look for external bleeding or any unexplained bruising. If hypoxia is suspected, provide supplemental oxygen and rapidly assess the need for transport. When gathering the patient's history, investigate their chief complaint. For patients experiencing a sickle cell crisis, look for physical signs such as swelling in the fingers and toes, priapism in males, or jaundice. These symptoms can indicate severe complications requiring immediate care. To fully assess the patient's condition, ask targeted questions. Find out if the pain is localized to one area or felt throughout the body. Ask if they are experiencing visual disturbances, nausea, vomiting, or cramping. Inquire about chest pain or shortness of breath, as these can indicate life-threatening complications. Obtain a sample history from the patient or a family member if they are unable to respond. Ask if they have had a sickle cell crisis before, when their last crisis occurred, and how it was managed. Determine if they have recently been ill, experienced unusual levels of activity, or undergone significant stress, as these can trigger a crisis. During the secondary assessment, focus on major joints, as these are commonly affected in sickle cell crises. Evaluate and document the patient's mental status using the AVPU scale. Obtain a full set of vital signs, paying close attention to signs of hypoxia, respiratory distress, or abnormal heart rates. If available, use a pulse oximeter to assess oxygen saturation levels. Continuously reassess the patient's vital signs and monitor for any changes in their condition. Evaluate the effectiveness of any interventions, such as oxygen therapy or pain management. If needed, adjust your treatment plan and prepare for rapid transport. Be sure to clearly document all assessments and relay important information to hospital staff upon arrival. For most hematologic emergencies, pre-hospital care is mainly supportive and symptomatic. If the patient presents with inadequate breathing or an altered mental status, immediately administer high-flow oxygen at 12 to 15 liters per minute via a non-rebreather mask. Position the patient for comfort and transport them as quickly as possible to a medical facility.